Well, it's getting started up, and while some other people filter back into class, I'm gonna go get you guys the space out of the fridge so they can sort of acclimate for temperature. Lamp. All right, so this isn't for points or anything, obviously. It wasn't the other time either, but it's just to kind of get us thinking again about what we learned about chapter 16. Well, it's been a while, so I thought we would go over it. So what immune cell produces granzyme and perforin? Do you guys remember which one that is? Yep, that's going to be the CD8 positive cytotoxic T cells. Good job. So next one, what is the first type of antibody produced during the initial contact with the pathogen? That one's going to be IgM. It's always IgM first. All right, which type of antigen is presented on MHC2? So yes, this is going to be, right? So this is going to be two choices, either outside or inside, right? So inside looks more like the 1 than the 2 does. So that's how I remember it. But so MHC2, stuff from outside, exogenous antigen. And that's going to be presented by APCs only, right? And one example of the 6 major functions of antibodies, I explain how it works. Actually, in the next slide, I have all of them. So we'll just go over briefly any of them. But if you could think of even just one use. So yeah, it could be easy stuff like coating, right? Or it could be antitoxin or any of that stuff, or opsonization, which I know is a crazy word, but as long as you're aware of the concept of what it is, all you have to do is recognize the word on the test. So, but yeah, so number 4, that is agglutination, causing all the bad guys to stick together with all the little antibodies and creating a big old globby mess so they can't do their thing. Coating, like we said, coat the bad guy, it can't do its thing. Neutralization, literally now not coating the whole thing, but just interacting with the docking molecules so they can't dock with the target. Antitoxin, coating the toxin so it can't do its thing. Opsonization is acting like a handle for phagocytes to grab onto so it can phagocytose easier. And then complement. Remember, complement can be triggered by 3 pathways. This is going to be the classical the lectin, and the alternative. So clearly this is classical. Antibody triggering complement is going to be the classical pathway for complement cascade. But the lectin one will be recognizing sugars on the outsides of bacteria, and the alternative will be recognizing LPS or other repeating molecules like LPS. So, kind of like the PAMPs. All right, so that's that. That's a little mini quiz about chapter 16 to get us in that mindset and remind us a little bit about what we've learned. Chapter 17 is going to be dealing with basically when your immune system isn't acting the way that you would like for it to, essentially, like it was designed to do. So this is any diseases of the immune system, either overreacting or underreacting in some way. So this is immunopathology. It's the study of disease associated with overreactivity or underreactivity, right? So when we're talking about overreactivity, this is going to be allergies, hypersensitivities, and autoimmunities. And yes, we're going to go into all of those, but hyposensitivities, when your immune system isn't reacting enough, I'm literally talking about how your immune system isn't reacting enough. Like there isn't enough of a response there. Either you have a genetic abnormality that you cannot respond by making antibody or something like that, or there is some sort of acquired immunodeficiency. And if you can't tell them, you know, AIDS, right? So that's a very good example of an acquired version of an immune system deficiency. So hyposensitivity, underreactions. So we're not going to actually start with the hyposensitivities, but for some reason it was always at the top of this. So hyposensitivities, we have primary versus secondary. And that's basically kind of what I was describing. Primary is going to be whenever you got it genetically. Okay, so you had it from birth. And then secondary is going to be you got it after birth. Okay, so at some point you acquired it. You didn't have it when you were born. So we'll remember that. Okay, I had that up there. Anyways, better respect for the test. These are the types of things that I'll leave up there for the test. You guys will be like, don't tell her it's up there. Anyway, so then the hypersensitivities, your immune system reacting to things that you do not want it to be reacting to or overreacting to something. So allergies, blood associated reactions, and immune complexes and cell mediated reactions. And all that might sound a little vague or completely unclear to you right now, but yeah, that's what we're going to be doing in this chapter, is going over that crap. So we're going to start with the hypersensitivities first, and we're actually going to break down each type, the 4 types. Let me erase this so I can actually write more. Read that in my face or something. Still nice. Work very well, actually. Kind of annoying. Okay, anyways. Again, just like every other reaction we can have in the immune system, you can be responding to something from inside or from outside of the body when you're having these overreactions. So maybe you're thinking like, well, what could you be overreacting to that actually came from inside of the body? I'm talking about yourself. So that is, you know, autoimmune diseases. You shouldn't be attacking yourself, right? We've already talked about how in the last chapter, actually chapter 16, how you should be eliminating the clones that are self-reacting. What happens if you didn't eliminate them, or if they got activated when they should have, you know, had a chance to be eliminated and just hadn't yet. So that's the idea of stuff from inside in this particular case with the hypersensitivity. Everything else is going to be from outside. Even when we're talking about the blood type and stuff like that, when you're reacting in the blood type ones, the type 2 reactions, they are going to be from blood that's not from your body. So that's the idea with those. I'm sure you guys have probably not thought much about why it is, you know, it's such a big deal when you have to have your blood type given to you. Or maybe you have, and maybe that makes sense to you. Well, if you have A, you can't get B blood. Maybe that makes sense to you because, like, yeah, okay, well, B isn't what you have, so naturally your body can't use that. Well, it can't just not use it. And we're going to get into what is actually the real problem, in fact, as we go through that. So yeah, if you get a blood transfusion of the wrong kind of blood, And what's happening is it's not like you can't just not use it. If you're low on blood, sure, you need blood, but your body's going to see it as foreign and attack it like it's a foreign invader and destroy all of those cells that are being pumped into your body that are meant to be life-saving. And then you've got this whole other problem on your hands. So we'll get into that's kind of ridiculous. But this stuff is really applying that immunology stuff, taking it out of the disease context and putting it into a little bit more of the other side of the medical situation. So we'll start with type 1. So as far as our hypersensitivities, so type 1, these are going to be our allergies. And then this is going to, you can divide it into atopic and anaphylactic. I'm sure we've all heard of anaphylactic. Maybe you think you haven't heard of atopy before, but you've probably heard of somebody calling something like atopic dermatitis or something like that. Anyways, that's going to be localized. So these are hypersensitivities where your body is overreacting to something that like a pollen or something like that's outside of your body that you normally wouldn't be reacting to. Peanuts, shellfish, penicillin, anything that you could be allergic to. Typically, once you have been desensitized the first time, you will react almost immediately upon every exposure thereafter, because that's your memory response of your antibodies being, responding in that case. We'll get into in a second. So we have the differences here, atopy and anaphylaxis. Atopy or atopic reactions, they are going to be dealing with the local. So it says chronic local allergy, and I don't mean like it is you are allergic all of the time, constantly having an allergic reaction. That's not what we mean by chronic allergic, okay? What we mean is that for your entire life, you are allergic to cats. So at any point, whenever you see a cat, you'd be allergic to it, for example. So that's a chronic allergy, not having like constant allergy reaction anyways. So anyways, then we have, so these are local atopy. And there's some that are going to fall into this category that you might not consider as having been atopic reactions before, but they do fall into this category. Basically, if it's not anaphylaxis, it's falling into that other category, okay? So anaphylaxis is going to be a systemic allergic reaction. So you're reacting all throughout, all of your tissues in your body essentially are reacting all at once and being affected all at once by this reaction. And it does not take very much of the thing to elicit an anaphylactic shock. All right, so why do we have allergies? We've mentioned this before, I think, but in third world countries, they just don't have allergies. They don't have any kinds of allergies. And it's not just because, it's genetically in our genes or something. It's that we believe anyways, that their immune systems are trained on what to do with their IgE and with their eosinophils and that sort of stuff, typically because they are exposed to parasitic infections. And that's what these systems are set up for, dealing with naturally. We don't have parasitic infection. We have some that you can get exposed to in the US, right? Like toxoplasmosis, but it's not like it would be in a third world country where you have a variety of different parasitic infections you could be exposed to, even from birth, right? So and also on top of the fact that we're not being exposed to the parasitic infections, we're keeping everything else in our life as clean as possible in a way that, again, in the underdeveloped countries, they're not able to maintain, where we have Clorox wipes and we are able to, be bleaching our sheets and, all this stuff, where they're lucky if they can be boiling something or even be taught that they should, be boiling something to remove a contaminant, that sort of thing. So we are much cleaner. So we're exposed to less pathogens in general because of that, or less microbes in general because of that. And we are not exposed to parasitic infections. And those two things together, the cleanliness of the modern world, is what has inhibited our immune system from adapting appropriately to use our, IgE and eosinophil, our allergic response type cells. So we misuse them. They weren't trained properly from the beginning. So that's the idea. That's the hygiene hypothesis. The hygiene being we are overly clean and we aren't trained. Our immune system isn't trained properly because of it. It even says down at the bottom, delivery by cesarean section, by C-section, keeps the baby from being exposed to vaginal and stool bacteria associated with coming through the birth canal. That even then, you're being exposed to less bacteria. So that's just one example from right from the get-go that could be changing someone's exposure to bacteria in general and being trained on how to deal with these things on the immune level anyways. So that's a hygiene hypothesis. What types of allergens might there be and how would they get into our body? Most of this is pretty straightforward and obvious. We have the inhalants like pollen and dust and animal dander, that sort of stuff. We have ingestants. This will be like the foods, the peanuts, the shellfish. Then we have drugs also count because you would be taking them orally typically. You could have some drugs delivered injected wise, whether it's via IV or it could be actual shots like penicillin shot in your butt or something like that. So that would be injected, but natural exposure to an injectant would probably just be bees and wasps. So if you are allergic or sensitive to bee or wasp venom, it would not take very many stings to have you go into an anaphylactic shock if you didn't know you were allergic and you already were sensitized. Because remember, your first exposure to a bee, the first time you get stung, you probably wouldn't think anything of it. Just got stung by a bee and it hurt and you went on with your life. But if you got sensitized at that point and you made antibodies and they're ready to go, the next time you see a bee, you can die like very, very quickly from anaphylactic shock from this. It doesn't take as many bees as it did in My Girl, okay, with Macaulay Culkin. It doesn't take that long, typically. You don't need very many and you don't need too much of an exposure with that. So it can be pretty impressive, actually. So injectants, things are literally injected into you. And then contactants, things that you contact, whether that is, again, more drugs that you apply onto your skin, for example. Certain types of cosmetics or their ingredients. We have heavy metals, detergents. If you are allergic, a lot of people are allergic to laundry detergent. It's a very common allergy. So you might have to buy the free and clear stuff. I don't know. So that's a normal thing. So that's an example. I'm allergic to metals in general. Like I can do silver and I can do gold. And like if it's plated with those things, I'm okay until it wears off, right? So I'm usually okay with that. But otherwise, if it touches my skin, or like if I wear a necklace for a day that isn't those materials or plated with those materials, I will have a rash. Now for me, that rash, it doesn't look necessarily exactly like what you'd expect from an allergy, the type 1 reaction. My reaction looks a little bit more like what we will see in type 4 reaction, and we'll talk about that. But that can be, you can go either way, or you can have both potentially going on at the same time for some of these things. Latex can fall into either category as well. So type 4 reactions are related to your T cell response. And we'll talk about how that works, but if you were someone like me who's allergic to metal and you have a type 4 reaction to it, it's going to be very similar to what you would see with poison ivy reactions. We'll go through that later. All right. Anyways, this is how this would work if you have, your reaction. So first you're sensitized. This is the first thing. When I say sensitized, the sensitizing dose is the first dose that you get. Your body responds to it and makes antibodies to it. But that's it. That's the sensitizing dose. That's what you do the first time. First time, that's not a particularly helpful thing or useful for what your body thinks it's trying to do. All you're doing is making these antibodies and whatever and activating all that pathway. So we sensitize to the thing, we see it, it's carried to a lymph node. T cell helps activate the B cell in response to the correct quote unquote allergen. Our B cell differentiates and becomes into plasma cells making antibody. In this case, when we're talking about allergic reactions here, and these type 1, these are going to be IgE meeting. Wow, that was way louder than it should have been. What was that? Oh, okay, thanks. That was really loud. Okay, anyways, it's IgE. So that IgE is just the type of antibody associated with allergies or typically parasitic infections, but we're not dealing with those, right? Which is the whole problem. But IgE. So we've stimulated the IgE response, not the IgG response, right? And if you guys remember, IgM comes first, And then you differentiate according to whatever signals you're getting. In this case, whenever we were exposed to cat dander, we got signals to make IgE for some reason, okay? Now, because your body didn't get trained properly is why, but there's a lot involved in it, but basically just think about it that way. So it's doing it wrong. So now what happens is that IgE antibody, these Y shapes here, they'll stick their little constant regions, which are their functioning part of it, right? And in the case of IgE, its functioning region, its constant region, FC, will stick onto the outside of a mast cell and act like a little receptor on there. And it can change them out if it needs to, depending on what the reaction is going on. But once it has those IgEs bound onto it like a receptor almost, it can hang out like that for a very long time. We're talking like decades even, so that the next time that you're exposed to the thing, which is what's happening, if time passes, a long time even, you see the allergen again. So let's say cat dander, okay? Allergen now interacts with that mess that is on top of your mast cells, and now they have been triggered. That IgE on the surface of the mast cells, that causes the proteins to change their shape. That triggers the mast cells to release their crap into the bloodstream. Now, I say it's releasing their crap. It says more nicely down here, allergic mediators, okay? So what do I mean by allergic mediators? Whenever we have the interaction of IgE on the mast cells and we're releasing allergic mediators, what are they and why? Everything associated with any allergy you've ever had, the chemicals were released by these mast cells in this response right here. So that's why you have these. So what kinds of things would your cells be producing? Not a serious, kind of a no-brainer. Here's what I'm trying to say. So histamine, duh, right? Like, why do we take antihistamines? Because histamine is a problem when you have an allergy, right? So histamine, serotonin, leukotriene, platelet activating factor, prostaglandins, and bradykinin. If you guys have noticed, on the study sheet, I don't go into a lot of details about these, right? I just want you guys to be aware of what the process is. When you guys go into nursing or wherever, and you guys start working in that field, you might learn more about these things. I don't need you to necessarily know these in microbiology right now, okay? But I'm gonna go over them just so that you know kind of what we're talking about. So when you hear them again, it's not weird language. So prostaglandins are released. They're going to cause dilating of your blood vessels, so like reddening of your skin and stuff like that. Your nose might get red and all of that. Constricted bronchiole, so that means we're trying to prevent the thing from getting into your lungs even farther, but it doesn't know that's also causing it hard for you to breathe. So it thinks it's helping out though. Thinks it's something going on. Let's keep it out. It's not a good deal. We can have stimulation of nerve cells leading to like headaches or other pain associated with it. Histamines, serotonin, and bradykinin. These guys are involved, again, in dilating blood vessels. You can have skin manifestations as a result of that increased blood flow. So we get hives and things like this. This is clearly like induced in an allergy testing situation, but it's the same thing, whether you were saw it, naturally or otherwise. You can have GI symptoms. So it says increased peristalsis. If you don't know, which you guys probably do already, but peristalsis is the movement of your smooth muscles to move everything through your body. You can't control it. So moving things through your guts, basically. So when it increases that movement, it's gonna lead to diarrhea and vomiting. So typically associated with that. I mean, I've never had this in response to any sort of thing I've inhaled, but it sort of depends on how you saw the allergen and how your body was triggered to react to it, right? But we have secretory glands on the epithelial tissues. What does that mean? You're going to get a runny nose, like mucus production, basically. We have constriction of bronchioles over here as well due to leukotriene, which leads to airway obstruction from the constriction as well as mucus buildup. So a couple of these are leading to it making it hard to breathe. And it says asthma over here. Asthma is anytime you have an atopic, so local, yes, an asthma is an atopic. It is not anaphylactic. So it's just dealing with your respiratory system, right? It is like basically an allergic response to a specific thing that can cause the bronchoconstriction. And so we need to have something like steroids or inhalant steroids or something like that to help open up those airways so you can keep breathing because your body is doing a bad thing for you. All right, here's some example of some of the atopic diseases. Hay fever. Hay fever. You guys have any allergies to, like, it's been kind of bad lately. I feel like this last week it got kind of bad for a lot of people, but whether it's, you know, dogwood or it's those trees that smell terrible, what are they, the Bradford pears, or whatever kind of pollen or whatever it is, those are could be seasonal. We also have molds. You can be allergic to molds. That can be due to heavy rains and stuff like that, causing those to be built up, let alone if you have problems with mold in your own home. So they can be chronic and year-round as well, so they don't have to be seasonal. That could be cat dander and stuff like that. It's not limited to the season. That's all sorts of stuff. But yes, this can lead to what we call allergic rhinitis. Now, rhinitis, rhine, like a rhinoplasty, and like a rhino, like a rhinoceros, right? This is going to be your nose. So don't think too far into that one. Rhinitis, anytime you guys hear itis, and we're going to talk about that a lot in Unit 4, but if you hear itis, this is inflammation. So you have actual inflammation in whatever the tissue is that you're having associated with that word. But I say this because we have rhinitis, so we have inflammation in the nose cavity, right? There's going to be like vaginitis, where that's going to be inflammation of the vaginal canal. But if we have an infection of the vaginal canal, that is not leading to inflammation, potentially. That would not be a vaginitis. That would be vaginosis, like BV, bacterial vaginosis. There's no inflammation associated with that. Vaginitis results with yeast infections. So knowing the difference between these things is going to be more important later on. But in allergic rhinitis, if you're having an allergic reaction in your nasal cavity, go figure. You can also have rhinitis, so nose inflammation as a response to other things that aren't allergic, right? Like having a cold. So that's an example of another thing. So viral rhinitis, that sort of stuff. Infectious rhinitis. All right, anyways, then we have asthma. This is impaired breathing from the bronchoconstriction, usually due to inhalants, and doesn't require very much of them, as it says below. It doesn't require much to stimulate the response of your IgE and mast cell reactions. So, and it could be inhalants, it typically is, but it can also be associated with eating certain foods. Like we know if you have shellfish that you're sensitive to, you eat that, that can cause bronchoconstriction as well. That's just an example. So atopic disease, eczema. It looks like it is something that is affecting the entire body. It isn't. It's affecting all of the skin, but it's not the whole body. Okay. So this is atopic still. So we call this atopic dermatitis. So sensitization associated with the skin. You'll have, you know, weeping, encrusted lesions. This can be treated with some creams, but it's never going to be completely eliminated unless you go through certain kinds of allergy treatments and stuff like that. But you can't relieve this completely. You're always going to have it. You can't treat it completely with just creams. You're just always going to have to be applying them, unfortunately, or avoiding whatever the thing is that's making you most sensitive. Okay, so food allergies, most commonly thinking of peanuts, fish, certain kinds of fish, soybeans, shellfish. We say wheat, right? So we're talking about gluten here. That's an actual allergy. If you have if you are allergic to gluten, right? That's one thing. You can't just be sensitive to it. That's not a thing. I just want to be clear. There's still not a sliding scale. Okay, just want to be clear about this. So I'm a little sensitive to it, so I just avoid. That's not a thing. That's probably something else that's bothering you. All right. So, anyways, you could be allergic to it, and in that case, you want to talk to your doctor and actually get tested for that, and not just walk around saying you're sensitive to it, and now you eliminate it for whatever reason. You might want to get checked out for that, because that can cause. I don't know if you guys know this, but being actually allergic to gluten and you continue to eat gluten and have reactions as a result of it, Crohn's disease. That can cause, you know, inflammation in your gut, but that can be permanently damaging. So just going around, walking around being like, oh, you know, I can't eat gluten. If you really can't because you're allergic to it with Crohn's disease, then you need to go talk to a GI specialist and make a plan for what you should and shouldn't be eating, so you aren't causing permanent damage to your GI tract and possibly needing to have, you know, part of your colon removed. I'm not kidding, later on in your life, because this is a real thing for people with Crohn's disease. It's not like a trend to think that you're kind of sensitive to gluten. It's a serious thing for people who actually are. allergic to it. So you want to avoid it just because, that's fine. But yeah, if you think you really are sensitive, then you really do need to go to the doctor about it. Is what my point is. It's not a joke. It's not just a fashionable thing. All right, so if you are allergic to a food like gluten or peanuts or shellfish, obviously you're not going to react the same to all of these. If you guys do know anybody who has Crohn's disease that can't have gluten, like wheat basically, versus somebody who can't have shellfish, their reactions are wildly different in response to whatever they're allergic to. They're not when you have gluten, you're not going to swell up in your face and it'd be hard to breathe, typically like what you see with shellfish allergies, right? So it's just how the body was exposed to it and how it's going to decide that, it's going to be reacting in what tissue more than another tissue and all of that stuff. So that can be quite different from allergen to allergen. So you can have gastrointestinal symptoms associated with these: vomiting, diarrhea, and abdominal pain. And you can have just those, which is typically what you would see with gluten allergies. Other manifestations: eczema, hives, rhinitis, asthma, anaphylaxis. Anaphylaxis is not uncommon with what we would see with peanuts and soybeans and shellfish sometimes, right? So that's why people who are allergic to those things might carry an EpiPen with them in case they were exposed accidentally, because it can be that serious, just a little bit. That's why they have to put on those things that you might buy, or when you go to like Panda Express and they're like, have to put signs up saying that we prepared everything in an area where we have peanuts and stuff like that, so that people who are allergic to peanuts can be aware of, okay, now I know if I want to take the risk or not. Is that going to be a big deal? Which unfortunately is going to be up to you more than anything. But yeah, so that's the idea. You can just have GI symptoms. And I'll say this, I don't know what the deal is, but so I am allergic to whey protein, which is weird. Okay, that's weird. Let's just all agree on that. But I'm allergic to that, and I found out because I was drinking like those Premier protein shakes like you get at Walmart or whatever. I was drinking that for like breakfast. I'd have it in my coffee as like a creamer and that sort of stuff. I'm having it every single morning, and I just started getting like these pains at my stomach. It started off like just pain. It was quite severe. But then it got to the point where I was like sweating bullets and like doubling over, and I couldn't walk while I was in the pain, to eventually passing out from the pain. And it got that bad. So then I went to a GI specialist, and finally down the road got referred, and had a colonoscopy done. And he was like, well, you're allergic to something. He's like, I can't tell from the colonoscopy what you're allergic to, but you are, have all this inflammation that is very indicative of some sort of food allergy. And I was like, what would it be? Because like, I'm like, I was at that point in my mid 30s, and I'm like, where did that come from? Right. And what is weird. And then I remembered that I was having all these protein shakes. And I was like, what if you could be allergic to something like whey that you're exposed to constantly, pretty much, like cheese and milk and all these normal things you don't think about, have small amounts of whey. You're not usually eating like tons and tons of cheese, but now you're having whey protein shakes in mass. You're exposed to a lot more whey all at once. And he was like, well, so I cut that out, and I didn't have any more symptoms after that. But he was like, you should cut out all whey. And I was like, I'm not cutting out cheese. Like, I'm just sorry. Like, I'll risk the pain then, buddy. Like, that's just how this is going to go. But as long as I don't have like the protein shakes, I'm okay. I'll have flare-ups now and then if I do have cheese sometimes or something like that. But I know what, I'm doing to myself. I'm aware of it at least. But yeah, it turns out I was having this like chronic long-term inflammation in my colon for so long that I never knew about until it was just exacerbated by the whey protein shakes that I'd never had before then. So things like that really put it into perspective that you might not know your body as well as you think you do. I mean, I was like, 35 at that time, and I didn't even know. It's just crazy to think about. Suddenly now I have this strange allergy, and it didn't come out of nowhere. I probably had it the whole time. But anyway, all I was having was abdominal pain. I didn't have any other symptoms at all whatsoever. And that's just, I think, pretty nuts to think about. It doesn't have to be like what you would expect allergies to be like. So keep that in mind. If you start having symptoms like something like that, doesn't have to be that, but be your own advocate and speak up for yourself. So, because you know how it is, people in your life who know you probably would tell you like, come on, like your stomach hurts. and like roll their eyes at you. But like, if you know this is not normal and right, be sure that you're your own advocate. That's what my point is there. Anyways, so drug allergies, you could have just a rash from a drug, or you could go into full-on fatal anaphylaxis. It depends on how it was delivered. It depends on what drug we're talking about. Very common to have anaphylactic reactions to penicillin. If you take penicillin when you have mono, like some doctors just do the shotgun approach and don't even really care. Yeah, you have mono, here's some antibiotics. We all know, well, maybe we don't know, but hey, mononucleosis is caused by a virus. It's not a bacteria. So whenever your doctor is prescribing you amoxicillin for your mono, that's just him covering his bases in case it's not virus, so he doesn't have to see you again later. However, if you give somebody a penicillin type drug when they have mono, the way that their immune system is being activated, because mono is going to be in your lymph nodes, yeah, that's part of the whole feature of it. So that's where your lymphatic cells are going to be. So you're more likely to be activated to have sensitivities to drugs and stuff like that when you have mono. So it's well known that if you take a penicillin type drug when you have mono, you can easily develop a penicillin allergy when otherwise you might not be able to. I had in college, my boyfriend, at the time he got mono and they gave him a penicillin drug and he got this rash all over his body. And he was like, that was the worst part. Like, it was just so bad because at first he didn't understand why he was having the rash. So he's still taking his antibiotics. And like, it was just getting so bad. He had to go to the ER for it. And they're like, yeah, dude, you're allergic to penicillin. He's like, I've never been allergic to penicillin. It's like, well, you said you have mono, right? Like, that's why now you are allergic to, you are now, buddy. So it wasn't before, but he is now. So yeah, it's pretty crazy. So be on the lookout for stuff like that. Weird, but you can have allergies to all sorts of stuff. When we say aspirin, that could be aspirin or anything related to aspirin, like any of the salicylates, even salicylic acid can relate to that. Opiates, that's any of those opiate-based painkillers. If you're allergic to them, you can't have any of them. That can make it harder to treat someone's pain. All right, so systemic anaphylaxis, like we're saying, this is local. Atopic is local, and this is systemic. So we're having effects all over the entire body with anaphylactic shock. Usually it's going to be related to injectants, but it's not always. So bee stings and injections of antibiotics or serum, depending, are the most likely causes of this sort of thing. So sensitivity on your initial exposure, you got stung by a bee. So this is what it's talking about with sensitivity. Stung by a bee, just stung by a bee seemed like a normal situation. 10, 15, 20 years later, get stung by a bee again, have anaphylactic shock as a result. That is crazy. You can hold on to that for that long. But anaphylactic shock, man. So how do we figure out what you would be? Oh, I don't know why this slide's here. Seems weird positioning, but whatever. How do we find out what you're going to be allergic to? We have in vivo methods to determine this. So that is what we're talking about. In vivo is in the body, so in the living tissue. So what can turn into determining anaphylactic sensitivities as well as atopic. So it could be any of those sorts of sensitivities. Put a little bit of it under the skin typically, and then see if there's any welting up as a reaction. It's usually within 15 minutes. So they'll do this on like all over your skin, usually all over your back, if they want to test for a whole bunch of them at once, or on the arms if they're just looking, usually on the whole arms right here where it's softer skin. And then check it after 15 minutes to see if there's any welting. It says a wheal, so like any hive development in those areas, and then determine what you're allergic to that way. And get down to the nitty-gritty of it. All right, so let's say you have an allergy. How are you going to treat it or get rid of it or whatever it is? This is going to go through that. Anti-allergy medication. There's all different kinds that we can have, okay? It's not just as simple as Benadryl that is an antihistamine. That's not your only choice here. If you've ever had an allergy or had any sort of severe allergy or known anybody with asthma or you have asthma, then you know it's not just Benadryl that's available, right? It's going to be things like Benadryl. It's going to be things like steroids. It's going to be things like other things that you could have in inhalants to help. I don't know what kind of drugs, but there's all sorts of things we can do to either inhibit IgE production itself or a reaction to the IgE being activated. So we have oral versions that can inhibit activity of the lymphocytes and therefore the production of the IgE. So that when you're exposed to this thing, if you don't have mast cells that are already like preloaded with IgE, we're going to make more IgE always as a response anyways, but we can block that at least. So you can keep that from getting worse. So we can inhibit that. A lot of these have really significant side effects and shouldn't be taken for prolonged periods. Now, I want you to think about this is should not be taken for prolonged periods. Here, we're mostly talking about things like steroids. All right, so Benadryl's pretty tame. I don't know if you guys know that. It's like one of the tamest medications you can take. It's super safe. Now, doesn't mean start swallowing it every 10 minutes or something, but of course, consult your doctors. But I once had a root canal and I had this lazy old guy dentist that did it. And he didn't prescribe any like painkillers or any steroids for swelling or anything like that. He just said, take 8 Benadryl and then take one or two every 30 minutes after that to keep the swelling down, because it does control the inflammatory response. But that is like so old school, you guys. That's like the oldest of the old school, okay? But that's what he did. That's what I got out of this. And he didn't prescribe me any medication other than that. And I didn't even have I'm not gonna lie, I take very good care of my teeth. I brush, I floss, mouthwash like regularly. What happened was I knocked my tooth out. And so the nerve died. That can happen to anybody. So I don't think just because you take care of your teeth, you're in the clear. You're not, let me tell you. But anyway, so, but you don't want to take the other ones for longer periods of time or in mass amounts, because most of these are affecting your, like when I say that, steroids might inhibit the activity of lymphocytes and the production of IgE. Well, if they're inhibiting the activity of lymphocytes, y'all, they're inhibiting lymphocytes. It's not just for this one allergy, right? It's for your whole body that you're taking this whole drug, affecting your activity of your lymphocytes, your B and T cells for your entire body while you're taking this steroid. And you probably, if you have taken steroids, had doctors who were good doctors at least, should have told you that taking the steroid lowers your immune system and your immune response. That's why you don't take it for longer than you absolutely need to, and why a lot of times they won't re-prescribe it even if you think you need it. They'll be like, nah, dude, like that's enough. Yeah, not to mention it causes weight gain. I think most people know that though. All right, antihistamines, the ones that we're most familiar with. This is going to be like Benadryl. Nothing crazy there, right? So just prevents the histamine from binding with its receptors and doing its action. Next, we have epinephrine and adrenaline. I want you guys to always remember, for the purpose of this class at least, epinephrine is adrenaline. It just matters how you are approaching it in medical field versus just like science field and that sort of terminology wise, but they're the same thing. Okay. When we talk about epinephrine, we're usually talking about the injectable, epinephrine that you would get in an EpiPen or something like that. Adrenaline, we think of that as your body pumping it through as adrenaline, but they are the same chemical. Okay. So epinephrine or adrenaline, do not forget they are the same thing. A lot of times I will include that on tests or quizzes or something. So if you are prone to anaphylactic attacks, we will have you carry an EpiPen. It reverses the constriction of your airways and slows the release of allergic mediators to prevent it from getting worse. It has a very short half-life. However, if you have to inject your EpiPen, you pop your cap and you slam it into your knee and push the little plunger thingy, and you got your EpiPen and you're starting to feel better, that does not mean go home and thank God that you're safe. That means go to the hospital, is what it means. Because once that wears off, you could still be having a reaction to whatever it is you were exposed to, because that didn't go away. Only a reaction was stemmed. We didn't get rid of the thing making you react, probably. So unless you know that you can pull yourself out of that situation and make sure you're safe or whatever, which I wouldn't risk it, I would say if you had to use your EpiPen, you should be going to, hospital. Make sure that you're going to be under supervision so you don't have anaphylactic shock. It does not take long to die from anaphylactic shock. Okay, so that's why we say, like, the second, if you're allergic to peanuts and you start having that feeling of like your throat closing, you're supposed to reach immediately for that EpiPen right away. You're not supposed to wait 30 minutes and then see, oh, I'm still doing bad, because you'll be dead by then for sure. So if you feel your throat closing up and you get that EpiPen and you inject it, you go to the hospital as soon as you can. so that your throat doesn't close up again and then you die because you don't have another EpiPen. Most people don't carry more than one. So keep that in mind. All right, so that's the idea. It's a very short half-life, but it can easily get you to a hospital on time. If you happen to be worried that you might have been exposed, you're one of these people who's just paranoid that you're constantly being exposed to peanuts or something, using it is a dose that's not going to like cause you to have crazy heart palpitations to the point that you're going to die or something. But that's the idea. That's how it's designed, to be safe if you needed it, but you didn't need it, but to help you if you really did need it. So then desensitization is probably the best goal. If we can move to desensitization, that means you were allergic to cat dander. You went through this process of desensitization, and now you are not allergic to cat dander anymore, at least effectively, right? So we will expose you to small amounts of whatever you're allergic to provoke a different response than the IgE response, and try to overwhelm, that IgE response that way. So it's not very effective for food allergies, just because of the types of, you typically in food, it's going through your GI tract. GI tract is typically associated with IgA, and we just don't produce as much of it as we do IgG, which is the goal of desensitization. So I inject you with, you're allergic to cats. I inject you with little tiny bits of cat dander molecules, along with probably activators, cytokines, things like that, that stimulate IgG production. So why would we want more antibodies against cat dander? Because IgG isn't going to trigger the allergic response. It's not going to be involved with mast cells and bronchoconstriction and all of this. IgG, again, that's the workhorse of our antibodies. 80% of a reaction, if you are simulating IgG, 80% of your antibodies will be IgG. So when I say 80% of your antibodies are going to be IgG, and you also are making IgE against cat dander, IgG is going to overwhelm by far. IgG will come and bind up all of those cat dander molecules the next time you see them, and IgE won't even notice that they were there because of how effective IgG is at its job. So you're desensitized, but you're still having antibody production to cat dander or whatever. It's just we've manipulated your immune system to circumvent that whole route. So it's pretty cool how that works. Okay, this is strategies for blocking allergy attacks in general. The events in the allergy, we could have blocking IgE production. So that's steroids here. We can have antibodies that bind with IgE so they can't work. So that's monoclonal antibodies. We have, I don't know what this is, chromalin. I don't know anything about it, but it prevents mast cells from degranulating, I guess, releasing the crap. Antihistamines, they're going to counteract those cytokines like histamine from acting on cells. All right, you could just avoid the allergen. That doesn't, I don't know what to tell you, just avoid it. And then the third option would be desensitization, like we were talking. I don't know why there's bread in the picture. I have never figured it out. Every time that I lecture over this, I have not figured out why there's bread and all these tablespoons and stuff. Maybe that's what it is. I don't know. Or maybe they're trying to like make some sort of like correlation in, I don't know. It doesn't have words, so I have no idea. But anyways, you're going to make IgG that binds with the allergen so that the IgE and the mast cells can't do their thing and cause allergies. So that's that. All right, that is type 1. That was just type 1. So now we're moving on to type 2. These go by a little bit faster. Type 2, this is going to be dealing with the blood types. Here it is. All right, so there's 4 distinct blood types, A, B, and O. So it could be the A, B, O, and then AB is a type as well. Or RH. Okay. There's 4 blood types, A, B, O, and then AB. Okay, and I want to talk what that means and how we get there and everything like that. Basically, think of it as, you have your red blood cells, right? And on the outside of those red blood cells, we have this little platform. Okay, so we'll say all 4 have this little platform. I want to get it drawn so that I don't have to come back with it. I got to silence my phone, and every time like a freaking leaf blows by my Ring camera, it like alerts it that there's movement. All right, so we'll notice there can be 4 of these. We said A, B, and O, right? They all have this foundation. This is O. Okay, so that's O. They all have that. They all have the O base. Okay, so let's say next we have A. A has, let's just literally put an A in a circle up here. Some sort of A sugar on it. B, go figure, is going to have some sort of, let's put in this triangle, B, sugar. And if we are an AB, then you're actually going to have both the A circle and the B triangle. Okay, so these are just referring to sugars, markers on the outsides of your red blood cells. Okay. We have already talked about how an antigen is anything that your body can see as foreign and reacts to in the immune response, right? These molecules tend to be pretty good candidates for that, the A and the B, okay? You won't react to the O. Why? Because everybody has it as their foundation, okay? So everybody can get this. Can get it. Okay, so everybody can get the O, okay? But however, if you are O, to you, the A, that's foreign, right? That's a new thing. To you, the B, that's foreign. That's a new thing. So everybody, who can get O? Everybody. O's, I don't know how to word this. They can get, O's can get only O. But anyways, so A's, they see A and O, so they can get the A and the O. But who can get A? A can get A, because they have the A and AB. Let me see, can receive. And then same kind of thing with the B. So B's can get B's and AB's can get B's. The AB's can get friggin' anything. Because they see A as normal, they see B as normal, they see the foundation O as normal. So they can get, AB's can get anything. But who can receive AB blood? Only AB's. So we can see how there's like this dichotomy sort of forming between the O's and the AB's, right? So quite easily we can see, that's fine, we walked through this. I'm going to erase it because I don't like it. It's kind of all over the place, but the pictures they show later will make more sense. I just want to be sure I'm getting to this part of it. Yeah, we'll come back to that. And this is just talking about the genetics of this. You guys don't have to worry about genetics, so I don't usually go over this slide. But if you are interested, okay, we're talking about what you get from your mom and what you get from your dad. You always get one gene from mom and one gene from dad. Whether you like the person or not is not what I'm talking about. I'm talking about genetically, right? So we'll say this is from mom and this is from dad, right? So you can get one gene from mom that was an A or one gene from mom that was a A, and then your type is A. But let's say your mom gave you an A and your dad gave you an O. Your type is still A, because that base sugar, that foundation doesn't really count for much of anything. You still have the A sugars on there. So that's what matters, whether you have that. So O, you can see it as what we would call recessive if we're talking about genetics. So the other things always outweigh it. Okay. So if you have 2 O's, you get an O. Notice there's only one thing up there for the O to get the O. You have to have O, and that's it. That's the only way you can get that. In order to be a type AB, you had to get an A and a B, and that's the only way you can get that. But if you're an O, you can only receive O because you'll react to A and B because that looks weird to your body. If you're an AB, everything looks friendly and you can receive anything. So with the O, this is what we would call the universal donor, because anybody can get O. Okay, everybody has that foundation. What do we call AB? It's pretty much the opposite. It is the universal recipient. So yeah, so one example I have is my dad is a B positive. If my dad is B positive and I am A positive, and my sister is AB positive, this is truth, okay? My mom's never had her blood type tested ever, so she has to be an A, right? So that's that pretty much how that works out. She has to be an A. So we kind of know that, and we can break that down. And we would also know on top of that, that if my dad is a B, he has to have genetically a BO, because he had to donate an O, genetically speaking, gene to me in order for me to have just A. You guys get that? Because if he had donated, quote unquote, his gene that was for B to me, I would have to be AB. So he had to give me his O. So I know his genetic makeup is B and O, just from that. So we can break that down. My sister's an AB positive. She got a B from my dad. She got an A from my mom. And she's RH positive. We'll talk about that in a moment. She is the true universal recipient. She can get absolutely any blood type. However, because she is AB positive, her blood can only go to AB positives. So that's it. It's kind of crazy. That'll break down. This is a better chart than what I was trying to draw out. If you are an A blood type, you have A on your surface, so you automatically are going to see B as foreign. So you are anti-B. Same thing for the B. B on the surface, you are going to see A as foreign. Your AB, you have A and B on your surface. Neither of those are foreign to you. So you don't have any antibodies against any of that. It's all good to you. Your O, to you, you have neither A nor B, so both of those are foreign to you. You have antibodies to both of those. You would split that up better. But anyways, that's how you could break that down there. That's why O's can only receive O's. And that's why ABs can receive anything. And this is the picture of those antigens. You can see there on the O, you have this foundation molecule that's present on everybody. That's why everybody can receive O. If you're trying to determine somebody's blood type, typically you will have serum that is manufactured that you can, well, you have the patient serum and then you have this other antibody serum that you can mix with it. Anti-A or anti-B or anti-RH, whatever it is, and then see if it clumps up. If it does, we'll tell you whether or not it has A or if it has B or if it has RH, and that's how they determine blood types. If you go to Baptist, let's say you're a patient at Baptist or you have a patient at Baptist, say, and they are going to be going through surgery. And you know that they're going to have a pretty serious surgical procedure done, and so they're going to need blood. So you might call ahead to the blood bank and say that my patient, we've already typed them, they are, B positive. We want to be sure they have B positive blood, so we're not wasting O negative, right? Because that's valuable. It's gold, liquid gold, basically. Don't want to waste O neg, so we want to be sure we have enough B positive. Baptist says, okay, they only have a couple units of B pos on the shelf at the time. So they call OBI and they say, we need you guys to bring more B pos up here. We want this much or whatever. So they bring up the blood. And then when Baptist gets it, do they just put that B pos straight on the shelf? No. What do? They test the blood type, because they're not going to trust OBI did the blood type testing correctly. It's their job. They're FDA regulated and, American Association of Blood Banking regulated and all of this. But it's still going to be maintained by people, and it's up to people to label the things right. It's up to people to do the testing and set up the testing for the machines correctly. So to prevent any sort of mismatching or anything like that, then they will have at Baptist, the blood banking people will test it and be sure that it is actually going to be B positive or whatever it is. Okay. And they do that. That's real. That's something they do because it does happen that it's not the right blood type. So they sometimes will test that blood and it won't be B positive. It'll be something else. If it was B negative, that wouldn't be a problem, but yeah. Oh yeah, you don't want to be given something else. Anyway, so let's go ahead and move on. So we're gonna go, we already know about the universal donor and the recipient. You're getting the wrong blood type, right? So what happens then if I am A positive and I get a B positive? Let's say I have an accident and my dad brings me to the hospital and he's like, I'm B positive, she's B positive too. She must be no, right? So what happens is they will do blood testing. If they were to just go ahead and not do the blood testing, just say, oh yeah, B positive, totally, and then transfuse me with B positive at that time, then my body would see the B as foreign, start making antibodies against it, which it already knows automatically just because of my genetics that B is bad. It doesn't need to instigate a response or anything like that. It just start cranking out anti-B right away. And when that happens, that antibody comes in and attacks the Bs, right, that have been introduced. And that can activate the complement pathway and whatever else antibody does, right? That will all be happening to those B blood cells. Typically, when we're talking about complement pathway, it's pretty devastating, the damage that it can do. So we're talking about rupturing open the red blood cells that it's attacking. And your body then sees all of that as damage being done in your body, and it doesn't distinguish that it is, red blood cells from somebody else. So it's reacting in the terms of shock. So you go in through going through shock, and you'll have kidney damage because of all the breakdown of all these blood components and all the products dealing with attacking cells and everything like that in your kidneys. It's not very good on your kidneys. So you can die from that pretty quickly. It doesn't take very long. Really, I mean, you would die probably on the operating table if that happened. So that's pretty serious stuff. So yeah, it says death is a common outcome. You can also have fever, anemia, which did happen to actually survive it somehow. So what would they do if they saw that happening? Halt the transfusion, administer drugs to remove hemoglobin from the blood. They want to start basically filtering out that blood right away so that we're not having the kidneys get too overwhelmed by it. So that's what they'll try to do if they notice that's happening. All right, so moving on to RH factor, because I'm talking about A, B, and O, right? But what about the positive and the negative? I'm A positive, my sister's AB positive. What does that mean? The most common blood type, by the way, if you're interested, if you don't donate, you don't know this already, is O positive. So it's a pretty useful one. Anybody with a positive can receive O positive. So it's still pretty useful, maybe not as useful as O negative. The way that the positive and negative work, we call this the RH factor. The way that it works is you either have it or you don't. So if you don't, you just don't. Anybody can receive negative, like the same foundation again, right? But if you have it, then you have it. Okay. Let's see. You're either positive or you're negative for it. You have it or you don't. The reason I'm bringing it up is if you are an RH negative mother, this is the most common example that you probably see in medicine for this. If you're an RH negative mother and it's your first time having a baby that is RH positive, first time carrying a baby that's RH positive, your body will see the RH positive marker as foreign and start making antibodies against it. Now, that doesn't exist until later in the pregnancy. And if we remember correctly, it takes a while to start triggering and making antibodies against something. I don't know how to turn this off. I'm not smart enough for this. Right. Okay, so right, RH. So if you were RH negative, you see the RH positive, it's just a marker or not marker. If you have it, it's foreign. If you see it, it's foreign. And you start making antibody to it. It takes time to make antibody. It takes time for the baby to start having that marker on its cells also. Okay. So that is what's happening in the second image down here. Oh, geez. The second one down here. Okay. So that's your first baby. You would not even know about it. You would be Rh negative. Your baby, you might not even know that you're Rh negative. If your baby is born, you might not even know that it's Rh positive. Especially, you know, if you're going outside of hospital and going through, you know, midwives and that sort of thing, and having a doula or something like that to have your baby, especially if it's like your second baby, your first ones were Rh negative. If this is your first Rh positive, you didn't even know this was like going to be an issue. You didn't think about it being an issue. However, the second Rh positive fetus that you carry, you already manufacture antibodies against Rh. So now once that baby gets to the point that it has that marker visible on its cells, we start having the same thing happening in that baby as we did in your blood transfusion. So the antibody is going to start acting complement and lysing, basically bursting, breaking down those red cells in the baby. The baby's a lot smaller than you are, so the baby's not going to stand a chance. So what happens is if you are somebody that has Rh negative blood type and you had a Rh positive baby originally, and this is your second one, the odds of you giving birth stillborn is high, very high. And if you think it doesn't happen today, you are wrong. I've had several of my students say that it has happened to family members or friends or patients. Still happens. Usually happens because people didn't know their blood type, didn't know their other baby's blood types. Oftentimes it'll be because they moved, their doctor didn't inform them properly at the original location what their situation was. So they didn't think to mention it. Yeah. So, I mean, if this is the case and you aren't getting any treatment whatsoever, almost always death of the baby, almost always. This is not something that is like sometimes it dies and I'm scaring you. No, no, no. It's going to die. That baby will die. And so that's why this is so important. If you are pregnant or if you know somebody that is pregnant and I would highly recommend them getting their blood type tested and probably their partner's blood type if they can, find out the risk of it being an Rh positive fetus. And if there is any risk at all and you've been pregnant at all, I would say go ahead and talk to the doctor about RhoGAM if your doctor isn't already approaching you about it. You get RhoGAM somewhere around halfway through pregnancy, somewhere around 20 weeks, I believe. And that's because that's around when the body would be seeing those positives. So we don't want to give it too early because we want it to last throughout the rest of the pregnancy. It can last weeks and weeks. You only need one shot typically. If there's any bleeding associated with the pregnancy, then they'll give more than one shot because just in case we want to be covering all of our bases, make sure we're protecting the baby. But yeah, so they'll give more than one, sometimes up to 3 shots. But RhoGAM, that's what RhoGAM is. It's going to help prevent those antibodies from attacking the baby. If you guys have ever heard of it, I'm sure you guys have heard of people getting it. You may have gotten it yourselves. Probably didn't really understand about it, but it's extremely important. Be sure that if you guys are working in that sort of setting that your patients are aware of any risk associated with it. Hemolytic disease of the newborn is what that's called. Hemolytic, hemo, blood, lytic, lysis, breaking open of the red blood cells. All right. Type 3 is going to be the immune complex diseases. So I believe type 2 was IgG. I don't know if it talks about it. I'm trying to find it. I think it is IgG. Anyways, whatever. But I know type 3 is going to be pretty much anything besides IgG. Type. This is not meant to be anything too crazy. If I have some sort of a disease, let's say strep throat, okay, and I have antibodies around in my body that are like hanging out for strep throat and whatever, and there's strep parts that it interacts with and all of this, and then this will be interacting with another piece, and this will be interacting with that piece. And whatever, they'll all be binding up together, making this big old like association, sort of like when we think about agglutination, right? It won't be in like this big old mass. We can have antigen, antibody complexes. This is immune complexes, that's what these are, hanging out in the bloodstream for a while afterwards. It requires large amounts of antigen to start this formation, to make it enough of a problem that it could be a problem. It's not going to be like it says here. It's not like anaphylaxis where you need just a very, very little amount, because we had to create this weird complex. Okay. However, once we have these complexes, little bits that are all stuck with other guys over here, and this is another guy, and then this whatever, and so on and so forth, they're all stuck together, can get trapped in the small places in your body. So oftentimes basement membranes, so that means like the very bottom of underneath like your endothelium or something like that. So inside of your blood cells, blood vessels, they can stick on the inside of those blood vessels and get stuck there, especially in capillaries and joints and other tight places of the body like that. And then the body sees antibody there, and neutrophils, which we already know, because your neutrophils, we've got all these like granules in it or whatever, come and see what's going on here, and they attack this, except they're attached to your actual body. So now you're attacking areas that aren't actual active threats really anymore. They're just stuck up in your body, and you're creating this response to it. So damage to your own tissues, right? Imagine if it's getting in tight places like your joints, and that leads to the inflammatory response there. Imagine if it's getting into small capillaries like the capillaries in your face, and we have inflammatory reactions there with redness associated with them. If it doesn't sound like lupus and rheumatoid arthritis, it should. Okay, because that's exactly what happens. It happens with other things as well. But if this was strep, let's say you actually had strep and this is actually happening to you, and this is building up, it's not leading to autoimmune disease necessarily, then these can get stuck in your kidneys. And while it's getting filtered, so we already know that that's a delicate place in your body, filtering out all the waste and everything like that. So it'll get stuck in your kidneys, cause inflammation there, and cause kidney damage. This is acute post-streptococcal glomerulonephritis. I'm not going to be able to say it again. I only get it once a day. It's usually how it works. But this happens as a result of these getting stuck in the kidney, causing inflammation there, and causing kidney damage. It's usually associated with group A strep, Streptococcus pyogenes. And yeah, that's the strep that we're talking about here. Not everybody gets it, obviously, but some people, this can happen and cause this issue. All right, so that's all that I say about that one, apparently. All right, type 4. Let's move on to type 4. Type 4 is cell-mediated. If you're ever confused about what cell-mediated immunity is and what that means when I say it, and I've already said it a little bit in chapter 16, it's because this is the type of immune response that the cells are doing the work, not antibodies that they make, the cells themselves. So what type of response would that be? That would be the T cell response. So typically we will see symptoms about 2 to 3 days after the second contact with the antigen. What happens after the first contact with the antigen? You're just building up sensitivity. That's it. So you typically don't have any noticeable reaction the first time. But you're just building up, just like we do with the antibodies. It's the same thing with the T cells. Now, why does it still take 2 to 3 days though? Right? So we know with antibodies, like if you've already been sensitized, it's like right away, your response, yeah? With the T cells, that's not the case. Because your memory T cells, we only keep like a few of those guys. That's not enough to protect you. So we still have to proliferate those memory cells back out when we reactivate them. So that's why it takes 2 to 3 days. You guys are familiar with this actually, and you might not even realize it. The most common example for people who are going into the medical field would be the PPD test, the tuberculin skin test. They inject it under your skin, and like 48 to 72 hours later, you're supposed to return back to the hospital and have, occupational health read the results, right? That's because it takes 48 hours or so for you to show if you've had a reaction to it or not. And if there is, inflammation, if that area has swollen up where they've injected that protein, then it is indicative of prior exposure to Mycobacterium tuberculosis. This will pop positive for anybody who has had the vaccine as well, which is almost nobody who are United States citizens. Well, originally born in the United States anyways. People from outside of the United States often do receive, the vaccine for tuberculosis. So it just depends on where they're from. But yeah, you can, especially if you're from any of the Asian countries, a lot of them still give those vaccines. But so yeah, that's what they're looking for. That's why 2 days, because they put it in you and they're waiting to see if any cells come and react to it. If they did, that means that you've seen it before. And that means that you've had either have tuberculosis or you had the vaccine. So that's why they'll go ahead with the chest x-ray after that to confirm that. Because even if you are latent, there should be still evidence of it in the chest x-ray. All right, because you can have tuberculosis and not even know it. A lot of people aren't aware of that. Contact dermatitis. This is poison ivy or poison oak, or this is what I have with my jewelry, okay? If I wear the jewelry that does affect me, it's usually a day or two. Like I can go a day or two before I start having a rash or reaction or something to that really cheap jewelry or whatever. So this is where I see this, but it's the same sort of reaction as what we see with poison ivy and oak. What happens is you have dendritic cells in your skin. So it's just like macrophages in your skin. They recognize whatever that agent is. Let's say that it is oil from poison ivy. So from those leaves, and it binds with that and presents it, and it interacts with the helper cell, and the helper cell helps to activate macrophages and cytotoxic T cells that are going to go and interact with any skin that has those molecules on it, because it sees that as foreign invader inside of the self. So they see that as like a cell that's infected with poison ivy virus, basically, for whatever reason. That's how they see it. And then they go and attack and kill those cells. So the reason you get blisters, the reason you get oozing, the reason it gets so inflamed and you get such a bad reaction to this, instead of just like hives, is because we're actually literally killing the cells here. Okay? So that's why we'll see the development of that fluid. All right, it's also the mechanism by which graft rejection occurs. This is because, remember, if we have MHC1, so that's the stuff from inside of the cell, which is what we're talking about here, right? MHC1 picks stuff up from inside of the cell and presents it out there. However, when it is not picking anything up, it's still hanging out. It's just not got anything. It's just hanging. So if I take kidney from Lauren and put it into one of you guys, and then it's just sitting here, the cells in my kidney, because any cell can have that, right? MHC1 is any cell. So it's just sitting there, just chilling, thinking it's minding its own business. And you guys' body comes around, your T cells come around, and you're saying, I know that you're MHC1. It looks like you're presenting some foreign stuff, even though I'm just chilling. I'm not though. I'm not. And then your body's like, no, I see that you are. And then you activate your cytotoxic T cell pathway in response and start just destroying the kidney that you just got in your body. So that's how that works, because this looked foreign to your body, essentially. So that's all usually MHC1 that's going to be the issue there. So we want that MHC1, if you're going to be receiving an organ, to match as closely as possible in order for donation to occur. Those MHC1 molecules. And so that's usually where all of that testing is going to be occurring. It's just for that. So there's two kinds of rejection you can have: host versus graft, which is what I was just talking about, is what you typically think of. And then graft versus host. So host versus graft, your body sees my donated kidney in it as bad and tries to get rid of the kidney, okay? In graft versus host, this other one, your body is chilling and enjoying its little life. You got some bone marrow transplant because of you had to have radiation because you had leukemia or something like that. And the cells from that bone marrow recognize your body as bad and they start attacking you. So whatever came from that bone marrow is now seeing you as foreign. So that's graft attacking the host. Okay. There's different kinds of grafts. Autograft is going to be from yourself. Isograft is from an identical twin. Allograft, this is going to be genetically different individuals, but still humans. And then xenograft, that's going to be different species. So isograft definitely has to be an identical twin. If they are non-identical twins, or like my sister, for example, want to donate to me, that's still an allograft, no matter what. Okay. So xenograft, that's going to be, a lot of people don't think about it, but it's like pig heart valves or cow heart valves, those sorts of things. You can get tissue from them as well. So other types of transplants, where can you get this from? When I worked in the transplant lab in Baptist, 99% easily of the organs that we dealt with came from brain dead donors, not from living people donated to their loved ones. Even kidneys, most of them came from brain dead donors. The problem is if you want to donate your kidney to somebody, and we had people who were just like wanting to donate a kidney anonymously to somebody. Like the guy one time I saw it. A guy came and was getting tested and everything like that for just donating out of the kindness of his heart, I guess, a kidney. Maybe he knew somebody that had gone through something like that or died from it. I don't know what his story was, but that was one time. Even the cases where you have like people who know somebody, or if you have domino transplants or something like that, it usually falls apart because somewhere there's a kink in the armor. And what I mean by that is, how am I always over this way? You guys never say anything. You have to say something. I know that we're right next door to lab, so it's not that big of a deal. So as long as I start on time over there, I'm not that worried about it. But yeah, you guys are allowed to tell me. Anyways, so yeah, usually it's going to be brain dead donors. You have live donors that are people that are donating to others. You have actually deceased people. You can get corneas from actually, like from people in the morgue and stuff. And then we have fetal tissues as well that can be associated with that. Autoimmunity is anytime any of this stuff that we've talked about, any of this has to deal with attacking your own cells. So here's the different kinds of hypersensitivities associated with these. Molecular mimicry are usually what is associated with causing a lot of these. So that means that like when we're reacting to strep or something here, if it looks like our stuff, then these antibodies will hang around and attack our stuff too. So that's molecular mimicry. We think that's the case with rheumatic fever and psoriasis. Other infections associated with this, type 1 diabetes might be, and MS, multiple sclerosis can be triggered by viral infection. Just depends. We also think that the gut microbiome is basically crap nowadays and isn't training our body correctly the way that it should. We eat crap. We don't go outside as much as we used to. We're not as exposed to the outside. You know, we use a lot of antibiotics, stuff like that. So our gut biome that is supposed to be training our system isn't working the way that it would. These are just looking in deeper to lupus. Then we have rheumatoid arthritis and Graves' disease, that is your thyroid being attacked, causing hyperthyroidism. Type 1 diabetes is autoimmune. A lot of people don't know that. Attacking the pancreas cells, then they won't make insulin anymore. And then multiple sclerosis is the covering of the nerves, leading to problems, numbness, pain, muscular weakness, all sorts of stuff associated with that. We think that's associated with human herpes virus 6, HHV6. Okay, for the immunodeficiency diseases, really quick, primary is going to be stuff present at birth, so some sort of genetic error. Secondary is going to be acquired after birth, so usually an infection or some other exposure to something. With the primary, there's a lot of different ones. I'm not going to make you guys know any of these, but I will mention just briefly the X-linked SCID. This is the boy in the bubble disease. So they don't have really any immune system. Their pre B and T cells can't develop on any further from pre. So they don't have an immune system basically at all. They don't have any B cells. They don't have any T cells. Anyways, it's X-linked and it's boy in the bubble because I don't know if you guys know this, right? But it seems obvious, but women have two X's. We have XX. So if you have a messed up gene on one of those X's, the other one can carry it. But if you're a male, you only get one X. So if they have a messed up gene on that X, they get whatever it is. So that's whatever it is. So it tends to be only men that have X-linked SCID, which is severe combined immunodeficiency. But there's all different ones that can occur. Any of them going down the T cell pathway, which is the top one, tend to be worse because the T helper cells are needed to activate the B cell pathways as well. So it's like just as bad. All right. A gamma globulinemia is dealing with not making antibodies. So usually we don't see all of that gone, just deficiencies in it. And then T cell deficiencies are usually more harmful. This is a little girl that has DeGeorge syndrome, where she has an abnormal development of her thymus, and therefore her T cell pathway is disrupted. Anything, as she's a child, a lot of those normal infections that she would get potentially, most people don't get bothered by, she could die from. This is SCID, so boy in the bubble, basically just don't have any immune system, and you usually see symptoms associated with this within days after being born because they can't even have like normal bacteria around them, and often die young. So secondary, this is acquired somehow, you didn't have it at birth. Infection, non-infectious metabolic diseases can lead to this, chemotherapy and radiation. AIDS, obvious one, right? This is an acquired one from infection with HIV. It affects T helper cells, and those T helper cells are going to affect your T cell and your B cell pathway. Cancers, if you have anything relating to your immune system, like leukemia, plasma cell cancer, or thymus tumors, these can, of course, affect your immune system as well. There, okay, we did it. Okay, there it is, guys. Take your pictures. We'll head right over to the lab. It's a pretty easy one in lab today. You'll definitely be leaving early, even after this. Probably, yeah. It was yesterday, anyways.